You are allowed to speak. Okay, so here is a story of a 23 years old boy. Quickly, I'll tell you, he presented with two symptoms. One was shortness of breath, and he had episodes of syncope where ventricular tachycardia had been demonstrated, and he was implanted a AICD. Faisal? So this is the echo which we did for him, and straightforward, the diagnosis was very clear that probably LA dilated, LV dilated. Please keep seeing it, and then I'll put a question across to our younger colleagues. So very flail kind of an mitral leaflets. Where is the flaw? We'll have to find out. If you look at this etiology, most people will say that it is mitral valve prolapse. Little ill-defined, according to me. Grade of MR, clearly severe, though I have not put color in it, but it is clearly severe because I could see a large area of non-coaptation. Large area of non-coaptation means it means that the vena contracta is high. What is vena contracta? Vena contracta is the color flow representation of non-coaptation. Need color flow? Okay, we'll say. So people who were debating whether it's a mitral valve prolapse or not, here is a more unconventional view, but clearly this is mitral valve prolapse. Short axis, mitral valve prolapse, 3D, not very clear, but here it is a grade 3, 4, 5, 6, whatever you want to call it, of mitral regurgitation, because here it's a curling up of whole of it. It starts as a blue jet, and it turns up and turns around as a red jet because it is all a swirling jet. So severe mitral regurgitation. Severe mitral regurgitation, flail, mitral valve prolapse, TR. Now, here is the, I'll come back to this image at some point of time. This one, everybody see this, and then we'll come back to it. Again, this is the place where I caught hold and said, let the drama begin. Still image. Anybody who finds some abnormality in it? Nigat, I knew you will be a spoil sport. Tell me, what is it? Come to use the mic. Use the mic, please. Whatever you are saying is 100% correct. You are very bright. I always thought that. Brilliant.
So that is most probably a case of mitral annular dysjunction.
Not most probably, it is.
Thank you, sir.
If this is the mitral hinge point, and this is the aortic hinge point, then there is a big gap here, and this big Faisal is going to be on my target. Doesn't matter. Okay, so this is mitral hinge point here, and this is the hinge point of aortic. Now, why is it so important to diagnose mitral? Nikat, you are very bright. I always thought so. So this is where it is. Not very clear because there is some calcification here which is obstructing or whatever it is. So this is something which is, if you look at it, this is the hinge point here of mitral, this is the hinge point here of aortic, and there's a big area of dysjunction. Why is it so important to make a diagnosis of dysjunction in a mitral valve prolapse? For two reasons. Here, this is more dramatic. If you look at this here versus the hinge point of aorta, there is a gap. And this gap, people have calculated if it is more than 0.8 per meter square. Something, where have they got this idea from, the 0.8 per meter square? This is exactly from the Epsteins. In Epstein's also, it is 0.8 per meter square, which roughly comes out to be out 1 or 1.1 displacement. So same criteria has been used for mitral annular disjunction. If you look at this, this is the area where there is a mitral annular disjunction. More dramatic pictures. Why is it so important? Now, this is 3D. This is all to create some glamour out of the presentation. Otherwise, it would have been incomplete. This is the area of disjunction. And if MAD is the term used, mitral annular disjunction. And this mitral annular disjunction is very important to understand because A, is this a malignant variety of mitral annular disjunction or this is a benign variety? Anybody other than Nigat, please? Younger. Why? Severe MR can be there in any mitral valve prolapse, not necessarily MAD. I have already shown you the pictures. Dada, tell me the color of your hair. Black. Okay, ठीक है. Wonderful. He has an ICD. So obviously this is a malignant variety. But had he not had an ICD, what else did you want to prove that this is malignant variety? Which I'll show now. Okay, so this is what it is. If you look at this, you can see the ICD lead. This is to highlight that this is certainly malignant. And second point is the tissue Doppler, though not very classical, is showing something of a central spike in the systolic flow. And this is because when the mitral valve prolapses in systole, it pulls the inferior-basal segment, which gives a sudden spike. And this sudden spike is known as a Pickel-Hobbe sign. What is Pickel-Hobbe? Pickel-Hobbe is a German head with a central spike. And this was described in 2017. This was Lakshmi Muthukumar and Jamil Tajik, both of them of Indian origin. They have described that they took two sets of patients, one with Pickel-Hobbe sign, another without Pickel-Hobbe sign. And they found that the ones with the Pickel-Hobbe sign had 4 times more time chances of malignant arrhythmia. And this is what is Pickel-Hobbe sign. So there is, it can be in mid-systole, it can be late systole, but the sudden spiking is something. Our patient didn't have a very sharp spike, but if you look at it carefully, there is a sharp spike. So this is where I'll finish. And thank you very much for a lovely invitation. We are in a rush otherwise. And thank you very much, sir. It's always a pleasure and wonderful hospitality, excellent interaction. And thankful to you, Professor Fazlur Rahman.